Well, terrific to be here in Ottawa. I'm delighted to be the moderator today. You are in the right room if you're expecting a very thoughtful discussion about health data in the age of AI, sovereignty, security, and economic opportunities. I'm looking forward to what our panelists have to say and start to think about questions as you're listening. We've already heard a little bit about AMS Healthcare, but our mission is to advance a Canadian healthcare system grounded in innovation, rooted in compassion, and our medical history. I could talk a long time about AMS. I won't, but I will take this opportunity to draw your attention to our fellowships and grants programs in healthcare, compassion, and AI. Applications for funding for 2026 are now open with 1.5 million available in funding. So that's the promotion, and hope that those of you have a chance to take a look at the criteria, because it's a terrific opportunity. We have some wonderful fellows and board members here in the room. We are delighted to be joining the University of Ottawa Centre for Health Law, Policy and Ethics and Bruyère Health Research Institute as a sponsor for today's event. And so back to the program, we have a terrific room of health leaders here in Ottawa, and we have over 100 people joining us online, and that does not include what we understand to be a watch party in the Deputy's office in the Ministry of Health in Ontario. So hi there, and I hope you find this as elucidating as those of us in the room here. Our lineup of speakers is outstanding, and we have asked each of them to make some short remarks from their perspective, and then we will open it up for questions and discussions. I, of course, will have a few to kick off the discussions, and I can keep going, so I would encourage you to try and cut me off by asking your own questions. So I get to introduce the panelists, and we will start with Dr. Anderson Chuck. Andy is the president and CEO of the Canadian Institute for Health Information. He is leading national efforts to advance the collection, use, and governance of health data in Canada. His leadership is focusing on improving health data accessibility and quality to inform equitable health system transformation. Dr. Paul Hébert is the president of the Canadian Institute of Health Research and a clinician scientist and recognized for his work in palliative care and critical care medicine. He is committed to fostering innovation and ethical stewardship in Canada's health research ecosystem. Dr. Amol Verma is a physician scientist in general internal medicine at St. Michael's Hospital and the Temerty Professor of AI Research and Education in Medicine at the University of Toronto. He is a health services researcher studying and improving hospital care using electronic clinical data. He has co-founded and co-leads Gemini. You'll hear a fair bit about that, which is terrific. Canada's largest hospital clinical data research network. And finally, Dr. Kumanan Wilson. He is CEO and Chief Scientific Officer of the Bruyère Health Research Institute and a physician at the Ottawa Hospital. His research includes digital health, immunization, pandemic preparedness, public health policy, innovation, blood safety, and newborn screening, health ethics, law, and policy. He's a pretty good generalist, and loss of interest. And Vanessa will be joining us on the stage because you are going to be looking at some of the questions that are coming in online during the presentation, and so that we will be able to hear from the people who aren't in the room and have their questions answered. And with that, Andy, over to you.
Hello. Okay, fantastic. So first of all, thank you for having me. So good to be here. I could talk about this topic forever, but I only have a couple of minutes. I'm going to try to be to the point. I'm going to start off by saying that Canadians own the most valuable health data set in the world. Amol, in his paper with Fahad in the Globe and Mail, articulates it better than I can. Right? Diversity of population, single public play. It is more generalizable than any other data set, right? But with that, at the same time, Canada is overflowing, drowning in data, yet thirsty for information. Data remains siloed, unusable, and then therefore who pays, right? It's patients that suffer mortality, morbidity, unnecessary inefficiency, right? So we're data rich and information poor, and Canadians pay the price, okay? Meanwhile, geopolitics has uncovered some uncomfortable truths for us that threaten our national security, like medical supplies, our sovereignty, who owns our data, and our economic resiliency. And I just want to take a poll in terms of just elaborating on that a little bit. Who here, just show of hands, thinks that our medical supplies, 50% we get from elsewhere? Show of hands? Half? 60%? 70%? The hand should be, right? It's about 70%, right, that we rely on foreign actors. The other piece I want to connect is just around the economic resiliency and how it is intrinsically linked to health. Sometimes people think that you talk about health as a sacred cow. You can't talk about it along the same lines of economics. But the truth is, when you can't buy food and you don't have housing, you don't have all these things, well, that's social determinants. On the other hand, if you have a weak economy, it's really, really hard to sustain and fund health systems, right? We need to be thinking about all of these things as they connect together. So how is it that Canada owns the most valuable health data set and yet faces all these threats, right? That's a really interesting question. But the more important question is, where do we want to go from here? Where would there be the opportunity that could leapfrog the country and make it so that we are world leading? Well, health data is one of Canada's other rich natural resource. It is as important as steel, as agriculture, as energy. And if we could harness it in the world of AI, it would make Canada world leading. But it's a choice. Okay, it's a choice if we really want to go down this road. And for all the Matrix movie fans out there, it's really blue pill or red pill. Okay, do we want to take the red pill and really look at this in the ways in which we can make change? Because if you want to take the red pill, there's a catch. And here's the catch. The catch is the fact that the country has never looked at health data this way before. The country really hasn't looked at health as something more than a cost center. They've never looked at it as an area, as an engine for growth. And so the catch is the fact that this is not just a technical fix. It's not just about technology. This is a change in mindset in the ways in which we look at this asset and the ways in which we want to utilize it for public benefit. That's really what it is. So this is not a technical fix. It's much bigger. This is why it plays on being an economic strategy, a sovereignty play, a health system sustainability need, a patient health imperative. Data is not merely technology, and in the advent of AI, it really is the connective tissue that enables patient empowerment, health system sustainability, clinical improvement, and resiliency in our economy to be able to fund health systems themselves. But time is running out. The reason why time is running out is that this is a global competition. Be sure that other countries are thinking about this, if not already doing this. And so we need to start mobilizing. We need to mobilize first. We need to connect researchers with fundings, with academic institutions, with compute infrastructure, with AI institutes, and within a model of data access, governance, and stewardship, that last one being a CIHI plug, by the way. But we need to do this, because if not, we are going to be, unfortunately, left behind. Conservative estimates, 2 minutes, I promise I'm almost done. Conservative estimates of what this means for Canada in terms of its total value is around $9.4 billion. And done right with appropriate mechanisms of safeguarding and patient consent, this could be prosperous for all of us, for all Canadians. And that itself is actually the real prize. That is actually what it's all about. But realizing this potential is going to require all of Canada, not some of Canada. And I believe that we can do this, though. Canada can build big things, and building a modern health data ecosystem that transforms health from a cost center to a growth engine is today's big opportunity, and one that will catapult Canada, leapfrog us to the future and being world leading. Thank you.
Well, that's a hard act to follow. Thank you. Thank you, Andy. So, moi, je suis aux IRSC Dr. Hébert. Je suis un Acadien, fait que je parle dans les mêmes langues, deux langues dans la même phrase, donc je m'excuse d'avance, mais je vous dis clairement que je peux répondre les questions dans les deux langues. Most of my remarks will be in English, but I'm a professor here at the University of Ottawa, so I'm very mindful of that. So the mandate of CIHR is largely to improve the health, well-being, and prosperity of Canadians. It's clear in the Act. The prosperity bit is critical. Now, we have to appreciate that prosperity without equity is a non-starter, especially in Canada. So from my perspective, all of those determinants are necessary. What you heard Anderson say is an awful lot about the economic and health drivers in the system. I'm just going to take you back a little bit. Why would we want to do this? Why is this our big bet? Why should we go beyond infrastructure, batteries, energy corridors? Well, let me just tell you that from an economic perspective, the life sciences sector, broadly speaking, represents close to $2 trillion in our current economy. And it's one of the most rapidly growing sectors worldwide. Every country that has an advanced economy where we aim to improve productivity has technology as a driver. Technology, broadly speaking, that's not just devices, it's not just little apps, it's actually technology. Drugs is a technology, right? All of it. So if we want to grow our economy, and I believe we can, you've just heard why, life sciences is and should be a key driver. Just a few numbers, I said 2 trillion. The pharmaceutical industry itself is $82 billion worldwide. We own, let's just step back a bit. We own about 2% of the life sciences sector right now, so not that big. And we own about 3% of the clinical trials investments worldwide. Now, a decade ago, we owned 6% of that market. Now you say, well, that's not a big deal, 6 to 3. Well, that's 20,000 jobs, actually. It's $2.5 billion a year. And we've lost that market share. What Anderson was saying is in part why. We have all these trade barriers. We have inaccessibility of data. We have clinical trials that are difficult to launch. That's one, and one of the big reasons we fail with my investments every year, one of the impact portions, is we fail to commercialize. Now, this is not a bad news story. Let me tell you the good news story. Why would we think life sciences, broadly speaking? Well, in 2000, that was the time of the Human Genome Project, right? If you think back, billions of dollars, thousands of scientists essentially managed to sequence one genome. 13 years it took. Now we can sequence a genome over a weekend for $100. Think of that. In 25 years, in that short interval, we've gone to be able to basically sequence anybody's genome over a weekend. Now, you think that's cool. Well, it turns out we can actually edit the genome now with CRISPR-Cas9. 2 women working very hard across 2 oceans essentially won a Nobel Prize for CRISPR-Cas9. So we can actually edit the genome. It gets better than that because now we can understand protein unfolding in cells. We can understand how the immune system works in pretty unique ways, and we can design drugs very quickly. So my point to you is that we're in an accelerated biological revolution. It is real. It is happening in Canada, and we have some of the best scientists in the world, bar none. Every time I go to a university, and I'm going through them a lot, I just am amazed at the talent we see. Now, why are we here? Well, for me, it turns out we're also in an AI revolution. The issue here is they're converging. AI is going to enable us to look at drugs, the thousands of drug banks we see, and our chemists can now essentially run simulation experiments on new drugs within hours or minutes. We can actually design new drugs in a heartbeat. We can now see proteins unfold and discover precision medicine really, really fast. So we can image things we could never see and see patterns we could never do in a very quick moment of time. So my point to you is we're at a unique point in history. We have all of the best scientists in the world, or some of them anyway, a lot of them. And I think this is a reason why we need to follow Anderson's route. We need to unleash our data. And as Anderson said, I can talk about this for hours, but I'll put 3 use cases for you. The first is, imagine we could, and this is possible today, we can actually detect diabetes before it happens. We can then essentially do population-wide screening with image technology to screen for diabetic retinopathy in a heartbeat. Our current screening rates for diabetes, eyes, is about 10%. 10%, most common cause of blindness in Canada. So my perspective is we can do population-based analytics in a way that's completely unique to either predict disease or do secondary prevention in a way we could never do. He is going to talk about adaptive clinical trials and real-world evidence where we use these platforms to actually do clinical therapeutics. So we can accelerate our understanding of interventions, whether they work or not. And the third thing that's going to happen, our other big bet, is precision medicine. We can now design therapeutics in a way that is unique to you. And that is likely the wave of the future. So from my perspective, the reason we would do this is we're converging on 2 major elements, AI and data, and a biological revolution. So that's why life sciences, that's why this will transform our healthcare systems of the future. So we can talk about the health systems. I talked an awful lot more about biology, but you can imagine that a doctor's office of tomorrow is not going to be the doctor's office of today. And as a practicing doctor, I can tell you that's already true, and it's nowhere near like it is going to be. So AI has the promise to essentially, in data, which is the core of all this, for me, an AI strategy is not an AI strategy, it's a data strategy, actually. Without the data, it's useless. So from my perspective, he was right. And I do believe that we are on the verge of something amazing. And as a country, we just have to get behind it. That would be my pitch. And of course, we're here to talk about privacy and other issues, but we'll talk about that in a sec.
Merci beaucoup. C'est vraiment un plaisir d'être ici avec vous. That's the end of my French, but it is a pleasure to be here. What I'll say is, for those of us, I'm visiting here from Toronto. I work in downtown Toronto. I grew up in Halifax, Nova Scotia. And for those of us who are not used to being in the nation's capital, I will say it is still awe-inspiring to come to the place where, particularly 2 days after a federal budget are just announced, to come to the place which is the central of decision-making for our country, and be here with you all and at this incredible academic institution that is helping shape those ideas. So, and to add to that awe, I also recognize that I'm in a room today where there are as many people in the audience who could be on this panel as there are people on this panel. So I'm really excited to have a conversation with you and eager to hear from you all what you think, because these are complicated ideas and you're going to get sound bites from us up here, but how can we have a real conversation to move the needle forward? And I think that's a really extraordinary thing that Helen and AMS and Vanessa and the University of Ottawa are doing to sort of convene conversations like this. This is not a one-way dialogue. I come here, my perspective is as a clinician, so I'm a general internal medicine physician and a scientist. So I lead a hospital data sharing network, a research network called Gemini in Ontario, which has nothing to do with Google Gemini. We started sharing data for the purpose of understanding the quality of care in a small number of Toronto hospitals. During the pandemic, realized we really needed to share data to understand this unprecedented challenge we were facing. And we grew from 7 hospitals to 30 hospitals. And then the opportunity of AI further increased the importance of data sharing and understanding and pooling together large data sets. And now we've grown to about 40 hospitals. That includes about 70% of the province. We receive inpatient data from these hospitals, electronic medical records. We put that together with the data backbone that CIHI has been curating for decades and put together one of Canada's most usable and most used hospital research data sets to help us generate insights and produce cutting edge technologies and innovations, working with some of the people here in this room. to do that. What's particularly exciting is that we're taking that work that we've done with Gemini and now linking up with provinces across the country. So we were funded by Innovation Canada to build something called the Vital Data Platform. The Vital Data Platform will take the work we've done with Gemini and advance that so that we can collect data from more than 100 hospitals across Ontario, Alberta, and Quebec as the starting point. Collect that data daily, near real-time data, and make it usable for research and innovation, to put the right governance in place to responsibly make that data usable for partnerships with the private sector, for industry and innovation to take advantage of that. This is going to be hard work. It is going to be hard work to put all of that together, both technological work, although the technical solutions are there and feasible, and governance work and partnership work and collaboration and working from the ground up with patients, with Indigenous partners and communities, with healthcare providers, and pulling that together over the next 3 years. And that is the Pathfinder work. We're excited that there are 4 additional provinces that have raised their hands and say they want to be part of this initiative, creating a coast-to-coast network, BC to Nova Scotia. And we're really hopeful that then just is the launch board to a fully Canadian infrastructure. Even with the 3 provinces and the first infrastructure we build, the hospitals that will be connected through Vital care for 20 million Canadians. So what that means is the vision for Vital is real-time hospital data from 20 million Canadians available in one place with appropriate safety and privacy compliant infrastructure for research and innovation. That will be the world's best health AI infrastructure, period, hands down. That creates an extraordinary opportunity, not only to improve our healthcare system, but also for economic development, as Andy and Paul talked about. So I'm really excited to be doing that work every day and living through that process, a messy and challenging daily process of kind of negotiating consensus through this work, right? But it's an extraordinary opportunity, and I will say, it is striking to me, having now been working in this space for 15 years, to say that we have provinces putting up their hands to come together. That has not happened before in the same way. And so this fraught geopolitical moment we're in creates this extraordinary opportunity. So let's talk about, I'm going to talk maybe to pivot in the last 2 minutes and maybe seed some conversation for the rest of the time together. What are the opportunities? So let's talk really practically about the opportunities to benefit from AI in our healthcare system. Let's talk about today and let's talk about tomorrow. So today, we need to be clear-eyed about the capabilities of today's AI technology, okay? Today, we do not have a large number of clinical AI solutions that have been proven in large-scale randomized controlled trials or rigorous clinical evidence that you could say we should deploy across our healthcare system today. There is a number of them that are very useful, especially in radiology diagnostic imaging, absolutely. And there are a small number of other tools, early warning systems in hospitals that can identify patient deterioration. There's a handful that you could say, we should do this. AI scribes in specific clinical settings like primary care or maybe the emergency department. Outside of that, there is no technology yet to scale, okay? The current capabilities of AI are synthesized language, synthesized information, help us with operational tasks. So if you as health system leaders were to say, what should we do to use AI to improve our healthcare system today? I would say, let's focus on the customer experience and the operational efficiencies in our healthcare system. Because frankly, clinical decisions are actually a pretty small part of what a healthcare system does. And a huge part of it is like customer service and operational efficiency. And when we look around the world at where AI adoption is having impact and where in healthcare it could have impact that's relatively lower risk, it is that whole body of work. So let us today work to implement AI that makes our healthcare system the best customer experience and the most efficient operational system in the world. That should be our goal for healthcare leaders. Then the AI of tomorrow, that's what these guys have to create the infrastructure for us to build. That's what we're trying to create with Vital. For that, let me just say, please forgive me if I do not trust the same companies that created social media, which has created a generation of polarization and disaffection, or the companies that created electronic medical records, which created a generation of clinician burnout, to be the companies that drive forward tomorrow's AI, okay? Let us not let that happen. So what do we need to not let that happen? I think Canada has such an important role to play here because of our data, the diversity of our data, the high income society that has the IT infrastructure, it has high income and a high quality healthcare system that can be part of testing and experimenting, but most importantly, because of our people and our worldview. We are an open and democratic society in the way that there are increasingly fewer such societies in the world. We have a unique opportunity to shape the direction of artificial intelligence. And I think it's really incumbent upon us as a community to take that mantle. Andy talked about it being a unique small moment. We need to take that mantle and invent the AI of the future, not just inherit it from the United States and adopt it here, okay? So I think that we need to work on 2 tracks. Urgently adopt AI on the efficiency side and simultaneously invest in, it's gonna be a long-term play, like multiple years to invent AI technologies that are the clinically transformative technologies we need for the system that we want going forward. And so it's a big challenge, but I think we have the opportunity to do it together. Thanks.
Thanks. So lots of great content so far, and there are a lot of wonderful things about this country, but we do have some challenges, and 2 of the major challenges we're facing are economic growth. Even before the tariffs, we were projected to be last in the OECD in economic growth till the year 2030. And the other major challenge is we have an apex predator south of the border who says he wants to take us over, and he wants to do so economically. So how do we fight back? Well, it's really hard to fight back against the US economically. They're a juggernaut, they're enormous. But we have something, as people have identified, that nobody else has in the world, almost as an accident of our single payer system. We have truly unique population representative health data with an incredibly diverse population that looks like the world. And that's the lifeblood of AI. Like this is like oil. This is incredibly valuable. And I'm going to quote Amol here. This is from your op-ed. Over the next 10 years, global spending on clinical trials will exceed US $150 billion, and the global healthcare IT market is projected to be worth US $1.4 trillion by 2034. 1 in 4 US venture capital dollars is invested in healthcare goes to health AI. Canada can have one of the most valuable health databases in the world, but you've heard some of the challenges in using that data up until the present. But at the same time, we have fantastic leaders at our organizations who are championing this. We have fantastic scientists like Amol. Katie's doing great work with our committees. We've got Khaled, who is a world leader in data security. We have the people, we have the data. So this is a great opportunity for us to fight back against the US and also make our healthcare system better and grow our economy. The only problem is, while we may not be using our data, it's not implausible that the US is using our data. And that's sort of what we've been exploring in some of our sovereignty work. So what is data sovereignty? It's making sure our data are subject to Canadian laws and legal systems. And the challenge is, in hospital systems in particular, we have 3 major EMR vendors. They're all American, Epic, Cerner, and Meditech. But more importantly, where do they store the data? And they store it on the cloud giants, which are AWS, Microsoft Azure, and Google Cloud. They're fantastic companies, and they hold our data. And these companies are subject to Canadian law, which is PIPEDA is for industry, is the federal law, and the provincial law that could be substantially equivalent. And these companies have to adhere to both. But the problem is they also have to adhere to US law. And the Cloud Act in the US can potentially allow the US government to access any data held by those companies, even if it's on foreign soil. And why would the US want our data? Well, there are 2 reasons they'd want our data. One is we know they're obsessed with border security, so they might want to compile a database of Canadians, and this is a great way to access the data to do that. And the second is, Trump has said he wants the US to be an AI superpower, and we have the amazing health data that he could be utilizing. We don't know, but he would have potential access, and he uses arcane laws to achieve his goals, and he also can bribe companies with offers of contracts. So our data is potentially at risk. under the Cloud Act and under the current US administration. And this is less than a theoretical consideration. So this is sworn testimony before a French Senate inquiry into the role of public procurement in promoting digital sovereignty. So Microsoft's Director of Public and Legal Affairs was asked whether he could guarantee that French citizen data would never be transmitted to US authorities without explicit French authorization, and he replied, "No, I cannot guarantee it." He said that the US companies resisted requests from the US authorities when they are not well-founded, but that under the US Cloud Act, US companies can be forced to hand over data regardless of where it is stored. And this is a major, Europe's really worried about this, and they're trying to figure out a way around this. We are increasingly concerned about this in Canada. And so we, in our CMAJ paper, which I wrote with Mari and Michael Geis, we proposed some potential solutions. One is encryption by design, and we thought that encryption alone should solve this problem. But the reality is that if the data is in the cloud and needs to be manipulated in the cloud, it has to be de-encrypted and snapshots can be taken. So the second idea, which after September 11th, the concern with the USA Patriot Act could be used. So people thought, let's use data localization. Let's have the servers on Canadian soil. And we felt that was a solution, but interpretation of the current law mean that it's still vulnerable. It is a level of protection, but it still becomes vulnerable because it's still connected through the systems. What Michael Geis suggested is to replicate what Switzerland has done to protect data in its banking system, and that's to create a conflict of laws through a blocking statute. So these companies don't actually want to hand the data over. They don't want to lose customers. They don't, and if you can give them a reason not to, at least hold it up, at least allow it to negotiate, at least then be aware that a request has been put in, because right now we don't even know what's happening. And a blocking statute introduced into PIPEDA could be a mechanism to do that. Ultimately, we'd like to develop sovereign Canadian cloud servers. That could take a while. Those US giants are really good at what they do. I founded a company and we use AWS and they provide great service. But that was, I think, identified by Mark Carney as one of the projects, nation building projects, is to build sovereign Canadian cloud servers. Actually, there's another option that I spoke to someone at Google that they're offering, which apparently, this is my Mission Impossible reference, is the idea of air-gapped solutions. And so that's a disconnected system where the only way really to connect to the system is through USB ports and such. It's clunkier, but it is secure. And so apparently in Mission Impossible 1, that's why Tom Cruise had to break into CIA headquarters and he couldn't just hack in because there was an air-gapped solution. I just found that out yesterday. So it's almost going back in time in a way to provide the security, because that's how things used to be. But that is an option as well. But a group of people who've been thinking about this longer than apparently Europe and we have are our indigenous populations, and they've been working on indigenous data sovereignty for a while, and the OCAP principles of ownership, control, access, and possession are maybe principles we should consider looking at as we look at our data and adopting from them and learning from their experience already with trying to protect their own data. And so I'd just like to finish with a couple of points. One is, as has been identified, our data needs to be protected, but it also needs to be used. Like, what I can't stand in all of this is that we may not be able to use our data for economic purposes, and the US may be using our data for economic purposes, and that is unacceptable. But the worst case scenario is actually that nobody uses our data, because we do want, even if the US companies use our data, we want algorithm designed on our populations, or else we're going to have algorithmic bias, and it may not work here, which would be bad health outcome. So that it would be worse that they didn't do that and just built their algorithms on their data and imported them into Canada. The best case scenario is we protect our data from foreign entities, and we allow Canadian-controlled private corporations to use that data to deliver better health outcomes for Canadians and to grow our economy and grow great Canadian companies that we can then export these solutions globally.
All right. head is spinning. So we're sold on the promise. I think there's, our panelists gave us an incredibly compelling vision of the value of the data and what we can do with it, including, Amol, very nicely, where we would start to reap value. I think those of us in the room and beyond understand the capabilities of Canadians and the value of the data. I guess my question is, but it still feels like we're a little bit in catch-up mode, right? We've been innovators in AI research in Canada, a long legacy of that. But in terms of sort of systematizing the value proposition of our data, it does feel a little bit like we're kind of a bit behind the 8 ball, and we've actually got to accelerate our capabilities. So my question is, are the obstacles we're facing, and we've talked about some of them, are they sort of the same ones that we've had for some time, or are there some new obstacles that we need to address in order to get to the place that you have so generously described? Can I get anyone to answer that? Paul, do you want to go ahead?
Just a quick comment. I mean, actually, the first thing I should have said, we are 2 days post the budget, and two things came out in the budget, assuming it passes, of course, is that one, our country, our prime minister and the current government have made it clear that science, and broadly speaking, is a big part of our economy, our future, and improving health. So the other thing is, that was made clear because the granting councils and everybody else who occupies a bit of this space was supported to the tune for us of $1.7 billion, added to the 1.3 from last year. So it's a fair bit of money. Just wanted to highlight that. Thank you very much to the government. The biggest problem I think we have is we seem to, it's a balancing act. You heard on one side, we need to protect privacy. We need to ensure data is well used. Need to protect privacy. And on the other side of that balance is really the usage case and using it. So I would suggest to you that we haven't found that right balance for our society. We seem to allow use for companies, but somehow in healthcare and health systems, it's heavily guarded where no one can use it. If I go to the clinic and I tell my patients, for example, and I have, listen, I can barely access your data from the clinic last week because you were at another hospital or you were in your family doctor's office, they're kind of like shocked. If I were to ask them, we would like to use your data for, research or, to do other things that might actually provide you benefit. They ask me or they say to me, well, I thought you already did that. So the reason I tell that story is that the biggest problem we have is public trust.
Yeah.
If you were to start somewhere, if it's that our public doesn't quite understand what's there and not there, and then the issue of trusting our governments and companies to use it for their good, that particular social contract is not there. And that's priority number one. I just came back from the United Kingdom, and what was clear there is that trust was there. And the reason it got there is they spent a lot of time and effort to do exactly that, like a lot, and a lot of resources to develop that public trust, that engagement, which was very similar to what we were doing with Indigenous populations. I think Kumanan made the point, it needs to be done for everybody else too. So number one job, public trust.
And Anderson, is that what you were talking about when you talked about culture?
Yeah, I got so much to say. Thank you.
That was your opening act.
It was kind of my opening act. But really, that's what I was talking about, where this is not some technical switch, right? This is a different mindset that Canadians need to kind of, you need to have a more sophisticated conversation around the ways in which we want to utilize our health information. And it really is about balance. But right now, I would say it is out of balance. And I'm going to steal an analogy from Amol's partner in crime, Fahad, because I love this analogy, right? It's a highway. That's why we have speed limits, right? We set the speed limit to find our right balance, because if you set it at 0, you go nowhere. But here's an extension of that analogy. that Canada also has to avoid, which is a problem. We don't make it easy. Okay, so if you set the speed limit, let's say at 100 or maybe at 80, but the road is windy, goes through mountains, through tunnels, through wherever, you've effectively still made the speed limit at 0. Okay, in other places and jurisdictions in the world where they've been able to leverage that public trust, right? The speed limit is not 0 and their road is straight. That's what we have to do.
Anybody else want to get in here? Amol?
Yeah, obviously I very much agree. But I might, so if I think just a little bit to maybe adoption of like AI technologies in healthcare today. So just talking about that very like sort of narrow lens. So if you look in the United States, 2 years ago, we would have said no one in the world has really adopted AI technologies. Like Canada hasn't, the US really hasn't, other places. The last 1 to 2 years have seen quite a large acceleration of adoption of particularly operational AI tools. Like more than 90% of healthcare systems in the US are now using some kind of AI to support operational efficiency. So we've seen a much faster diffusion of technology there than we have here. A big reason for that is that you have large consolidated healthcare networks that have resources like a consolidated EMR across 150 hospitals or something like that, right? And that then is stored in a computing cloud, so they can get a vendor like a Databricks kind of vendor to put their data in a logical place. They can get a computing cloud and then get an AI vendor, and the AI companies know how to interact with that, and they know how to design a solution, and the market makes sense for a company to invest in like such a large scale partnership, right? Come to Canadian hospitals, which are like our most consolidated part of our healthcare system, and it's already so fragmented, right? We don't have anything at that scale. And then extrapolate that to home and community care or primary care, ambulatory care. Why would a company or an innovator come here and try to work here? You have to like have 10,000 conversations where you can have one in a different market. And so how do we solve that problem? I think this is where the work of like middle level organizations, and I don't mean middle level in any kind of pejorative way. What I mean is they sit in between the healthcare system decision makers and the healthcare delivery organizations. I think of something like Ontario MD, things like that, where we can create enabling structures to allow companies to engage, allow new technologies to come in diffuse. So for example, a vendor of record list, so that when hospitals or primary care doctors need to know, hey, I want to buy an AI scribe, where do I go to for that, right? The Ontario government creates a vendor record list for AI scribes. They say, these ones are safe from a privacy perspective, go ahead and do it. Like we need more of that to lubricate the system so that we can acquire these solutions without massive procurement processes at each individual organization. So I think we need that kind of middle tier to improve technology diffusion while we're doing this other really important hard work about building public trust, et cetera. And it's also why I think focusing on the like lower risk non-clinical stuff is a good way for everyone to start learning about these technologies, using them, seeing them in practice. I'll just give you one really clinical example, if that's okay.
Yep.
I'm sort of talking for a long time. There's a cool company that I have no affiliation with called Amplify. Some of you may know about them. Mohammed Al-Arakia is a physician leader in that work. They've started partnering with some different innovative startups. There's one that does like a clerical assistant that you like call and try to book an appointment for your family doctor, okay? I don't know how many of you have experienced this, but I experience this all the time. When I have to book an appointment for my kids to see their family doctor, it's like 8:59. I'm on the phone and I'm calling like 12 times, right? Like the bang, 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 I gotta get in front line, otherwise I'm gonna wait for 25 minutes, right? How many people have that experience? Like probably a lot of us. This AI chatbot interacts with voice, has enough of a decent understanding that it can actually get a sense of how bad your clinical condition is and triage things reasonably. And if you have 20 of those, suddenly you're just calling whenever you need to call and it's answering you and it's booking your appointment. Okay, that's not super high risk. You could imagine if I'm unhappy with it, I can escalate it to a human because I don't like the appointment I got, right? But suddenly we're not having everyone waking up at 8:59 competing for family doctor spots. That's a meaningful improvement to our healthcare system, right? How do we bring technologies like that? That is today's capability of these AI tools. How do we make that available widely? And I think that's where we need these privacy concerns for sure. So vendor of record, that's the role for government and these middle layer kind of organizations. And I think we can get that really well to move forward in a really concrete way today.
Kumanan, you want to jump in? And then I'm going to open up, anybody wants to ask a question, because we have people online, we'll go to the mic. And then Vanessa's got some from online.
So I remember, I think a decade ago when we launched Can Immunize, I got an interview with CBC and I was like all happy, but it was a gotcha interview about the privacy concerns about storing data on your app. And I'll be honest, most people weren't worried about someone else having the data. They wanted someone to have their data. Like they didn't want to get when you get your kid vaccinated, you assume the government has your data and you get the suspension letter and saying, well, I assumed you'd have the data. Like this is actually, I think the bigger issue is why don't you have my data and why aren't people using my data? And this makes no sense at all. And I think as we start telling the story of the innumerable missed opportunities for Canada over time, like in the Denmark example I just found out about, they partner with Pfizer and they've been running pragmatic trials for vaccines, and they just had the Danish RSV studies, which article in New England and JAMA, and they had the Danish flu study, 44 publications. This is, Denmark's not exactly a right-wing, capitalist type country, and they're partnering with industry. And so I think if we let people know these opportunities, the other fact is we have been piggybacking on the US a lot for their surveillance efforts. We can't do that anymore. Do we trust them to do public health surveillance now, vaccine surveillance? Like, we have to do it ourselves. So we have to make our data available, and there are going to be privacy concerns, but they're going to be, as Paul said, it's a double-sided coin. There are also substantial risks if we don't make it available, and we can bring industry here, we can create jobs, and we can produce science.
Great. Looking in the room, questions, or give you a sec to get to the mic. Welcome. Why don't you say your name so people know who's in the room, and then if that's okay.
Okay, my name's Jan Hatcher Roberts. I'm at Bruyère Health Research Institute and a WHO Collaborative Center. So I get what you're talking about, and I get the idea of improving healthcare and health improves the economy, and I get within a country what you're trying to do. What I don't get is, what are we going to tell the Minister of Finance we're going to trade at a trade fair, global trade fair? What is it that we're selling in 5 years? Is it an improved healthcare model that other countries would adopt? Is it data that, or is it the infrastructure that we are going to market? That's where I'm not connecting the dots, I guess, or.
Amol wants to jump in, and then Paul, I see.
It's such a great question. I think it's all of the above. So, okay, if you think about what are the marketable technologies, we'll just talk about AI, but I think there's so much on biomedical. So I'll let you talk about biomedical and life sciences innovations, right? Like maybe GLP-1s would be a great thing if we could sell them. I'll speak to the
$149 a month now.
yeah. But no, but let's just talk about from an AI perspective, right? Because that's been the lens for the conversation today. So there are so many services that you can sell around an AI economy. Our AI economy doesn't have to be the same as the American AI economy. The American AI economy is like massive data centers, big, huge models, ChatGPT, we can't compete on that. But we can compete on a huge range of services that are required to use those models. So to take a model like that, adapt it, implement it into an environment like an electronic medical record, actually have it work, have there be monitoring solutions to make sure that the tools work well, they work for this population. Like you can create a suite of software tools for that if it is adapted to a Canadian population, for context across multiple vendors and EMRs, because our fragmentation can be a strength. There's so many services and tools around that can be sold. Without giving away, Khaled has created multiple companies to create tools around responsible uses of these technologies, whether it's about privacy. Like there's a whole industry around responsible AI. And actually what's interesting is in the accelerating AI movement that's happening globally, right? Driven by a lot of Silicon Valley interest in, et cetera. People are giving up the space of the responsible AI. There is a long-term competitive advantage to Canadian values of conservatism, caution, diversity, and infusing that into AI services. Because as soon as the first big problem happens with an AI technology, everyone's going to look for the safe AI services. So I think there's actually an extraordinary opportunity for that suite of different tools and services. They're like software companies, software solutions, tools like that. There's a huge opportunity for that industry.
Paul?
Well, implicit in Janet's comment or question was, who are you trying to convince of the issue? This is a policy imperative,
Yes.
Helen, that you have
My
heard more
happy
than
place,
once in
my
your
happy
life.
place. Yeah.
So if we're talking to the Ontario government, it's all going to be about economic growth. If you're talking to maybe Manitoba, it's going to be about Indigenous sovereignty. It's going to be about health and quality and values. It's not that they're mutually exclusive. It's just that you're positioning essentially a policy with appropriate lens, wouldn't you say?
Yeah.
So in the current policy environment, federally that is, the economic imperative would dominate. I would also say that without health, how can we have prosperity? The two are, I mean, it was said more than once on this panel. If you hear us speak, about the economy, it's not that we discount health. It's just that they're intimately intertwined. And the principles of equity and sovereignty and everything else are also in that. So when you hear us talk, we give you different language, but the truth is right now, the economic imperative would dominate. What I was trying to suggest to you is that the convergence of the biology and the life sciences, which are really large economies in our country, as it turns out, is rapidly changing and growing. And that convergence in all kinds of ways, whether it's your encounter with a doctor and how it's made better, the clinical trials we run and how they become much more efficient so we can know drugs are useful, safe, and will offer benefit to our patients quickly. All of those things will be improved with luck and good stewardship with the use of our data and with AI. So my view is, if we're looking for the pitch is we will, I would say, increase our productivity by probably as much as 1% if we put this as a big bet. And that's huge. Right now, we're struggling. Kumanan said we were struggling. We are struggling. And I started to articulate to you that we can't grow our productivity through our resource-based economy. That doesn't happen. So if we want to do things, foreign direct investment is a good start. That's something of what we've just been talking about. But we have to grow our own economy in addition to that. And we have to find the sectors of activity that will do that. Mining is about a $200 billion export industry a year in Canada. It's 150 about. It's huge. You would know. You were in Ontario. It's mostly in Ontario and Quebec.
That's why we host the PDAC That's why we host the PDAC conference every year.
Yeah. So my point is that is huge. It's an export economy. It won't change, but it's an export economy. If we want to be as part of an economy of the future, we have to decide what it is. And I think in my line of work as a scientist and a doctor, it's all about data, whether it's qualitative data, I'm looking at Dawn there, or whether it's imaging data, or whether it's clinical data, or protein unfolding data, it's all data. And so from my point of view, one of the big challenges we have is it's completely inaccessible and not useful at the bedside. And so from my perspective, his dream is to make that data useful when he's at the bedside to make a decision, or to make a system more efficient, or to make a better decision. And as Amol pointed out more than once, and it's not a dream, it's gonna happen, that we can, we will be at a bedside. Kumanan was telling me the other night, he was on call the other night, and he used ChatGPT to make 2 diagnoses. Now, he made it himself, but he checked the diagnosis on ChatGPT. Then weren't you telling me this story?
Fess up, fess up.
Is this being recorded?
Yeah. No, but my point's not that. My point is that future you talk about, it's not that far off. And it would be nice if we Canadians had a huge chunk of that future.
Yeah, absolutely. Vanessa, do you want to take?
Yeah, so I'll provide Just a couple of comments that are coming up online, and then a question. So we've got some great comments. So one comment around, one of the big issues, data sharing agreements. This person notes that one of the single biggest barriers to patient mobility, of course, is data sharing agreements. Another comment, been thinking about the point raised on why Canada is lagging in AI adoption for healthcare, and some folks mentioned public trust or fragmented systems as reasons. But, asking, do we really want a single unified system, or could that centralization create its own power imbalance? So how do we balance trust and innovation without just handling all the control over to one centralized system? And then I'll do one more, and we can maybe sort of bundle some of them together. And this is about whether or not we can sort of do this on our own. So writing, China, Singapore, US, Gulf countries are investing billions of dollars fully aligned on AI as the way to drive their economies. Europe's trying to catch up, and they've got 33 nation states aligned on trying to win in AI. How can Canada realistically try to compete on its own, given our size and whether related to the game? Should we think about joining other programs? So some great questions coming up online.
Paul, do you want to jump in
Just
on
one
the
of them.
international collaboration?
Well, no, I could do that for
Okay.
sure. No, for sure. Actually, it's not international only. It's probably with the private sector. How do you compete with companies that invest hundreds of billions of dollars on compute strategies, right? The idea is we can't really. We can try to do our own thing, but as Kumanan was trying to suggest, some of the solutions will have to be working with them in a way that protects our data. And he articulated a few solutions. I think part of what's being said is, where are we going to be competitive? And what are we going to choose to win on? Do we want to invest hundreds of billions of Canadian dollars on compute when companies will outspend us and outwin us? So I think that's the nature of the question. So if you can't beat them, you got to join them. The challenge is going to be how to join them, as we've talked about.
Yeah. And I've seen Minister Solomon talk about, sovereignty does not mean isolationism. So we've got to pick our relationships and partners well. Daniel, over to you.
Thank you. So most of the data we collect in healthcare is gathered for clinical care, as you all mentioned, or system management, not necessarily research. It means that when used to evaluate quality or compare treatments, there's always this uncertainty. Are differences due to treatments, or is it still confounding factors? And so we need randomization. What would it take to embed the ability to run platform randomized controlled trials into the routine fabric of Canadian healthcare right from the very start, so we don't have a million? Once again, the fragmentation in this area to run a trial here is so hard. Everyone's learning for themselves for the first time.
Can we start with coordinate REBs or something like that?
Fantastic question. I think it's a question many people are holding, have different pieces of an answer to, and I think we'll all have to work together. But I think it's a shared vision that many people have. So I'll speak to the component of it that I've been working on, which is first, I think, shared and harmonized data infrastructure. So we need to be able to use our routine data. So, and that means right now, our vendors, health system vendors, do not have interoperability standards, right? Would love to see our federal government push forward legislation that started and hopefully will be reignited to force some degree of interoperability and also prevent data blocking, right? So I think there's an opportunity to work directly, that's a huge policy lever that would be enormously helpful. One step down from that is then we take the messy data and actually we can harmonize it ourselves, because there's lots of technological solutions, right? So that's the work I'm doing. It's get that data layer ready to be able to run clinical trials. Then above that, there's a governance layer, right? Which is we have to figure out, and again, harmonization of privacy legislation across our provinces would be great to help with this, but can we re-identify patients from that data and offer them the chance to be in a clinical trial, right? The UK mails out lists, a letter to 1.5 million people and says, do you want to be part of a cancer screening trial? And then 140,000 people say yes, right? And in 10 months, they've recruited a massive population sample. So can we make some tweaks there, legislative tweaks, technological tweaks, so that we can run those kinds of trials? The third part then is a culture at the clinical interface, I think that'll come really quickly. I think clinicians and healthcare providers would love to be part of innovative projects where they're, instead of caring randomly, we are randomizing caring so that we're learning as we go, right? So I think that's really, that'll be the easiest piece. And then on the governance side, maybe Paul can speak to harmonizing the ethics, like one project, one review, right? Like harmonizing that at scale. So actually all the building blocks are there, and I think we have a pretty clear roadmap to doing it, and lots of people who agree that we should do this. So hopefully 3 years from now, we're here talking about how we're running these large scale trials off of a platform like Vital or other platforms that are being developed with real use cases. Because I think we're really close to there. Like
Do you share that hope?
Well, what I will say is we're actually there. It's not that we're almost there. We're working with Vital, but others are actually using platforms in Canada. So I would say that vision you have, what that will do will scale it up, I would say. Several of our science, I mean, we fund platform trials with existing data, and we plan to incentivize it. I'm just going to take just a little bit of a step back. What do we actually need to get? I mean, we talked about public trust. That's a big deal. The other big deal is collaboration, because the other problem we've just heard is fragmentation in every way you can think of. Fragmentation, what I mean by that is siloed thinking and an inability across many agencies and departments to think with a common purpose. I'm looking at you because this is probably your life, I'm sure. So it's
unfulfilled quite yet, but
yeah,
still working on it.
This is a big bet, and it's an ecosystem problem, and these types of problems are generally not solved by government top-down approaches. They're generally solved by something called collective impact. You set up a strategy where it's a bit more top-down meets bottom-up, and in this instance, the top-down part is that you need a data strategy, i.e. a data infrastructure strategy, and a data governance, sovereignty, and other strategy. All of the things, including changing our laws. You need those two things to work. The agencies, including that are infrastructure related at the federal level, that's CFI and ISED primarily. And at the provincial level, all provinces have infrastructure investment. So imagine if you're thinking infrastructure for data, that means bringing that collectivity together with a common purpose. The same, well, fortunately for us in Canada, on the governance side, provinces own it, but we have a federal agency that it's a big part of their mandate. So we are now working together. And we need to do the same with compute, start thinking through that and actually programming. It's useless to build all this if an agency like mine or Genome Canada or the health charities don't want to work together to basically fund networks and projects and programs that'll make use of all of these things we put together. So I've just described to you the type of approach we need at the higher level, and folks like Katie, who's going to come up to the mic, and Amol, and the scientific communities are doing the bottom-up piece in Canada. What I would say is we're at a unique moment because of what's happening down south, all of these folks are willing to do things they've never been willing to do together. My only hope is the provinces see that light and I think they are. As I'm talking now to provinces and your former colleagues, there's a willingness to do things that they would never have thought before. So I think that we do have the moment, and I do think we can elevate and leap ahead and do what Amol was saying is part of his dream.
Andy, do you want to get in there and talk about how you're working with the provinces? Because I think you're making some progress, right?
Yeah, I think we are making progress. I mean, one of the things that I've been talking about that I'm really excited about is the governance and stewardship work that the Conference of Deputy Ministers have given CIHI the responsibility to do. And the reason why I think that is so pivotal is because it now is a means by which provinces can come together and collectively identify what the common issues are, prioritize a work plan to address them, and we get on with it. In a federated country like ours, we don't have the luxuries like the Denmarks where they don't have that, and they make policy, they make the investments, and they go. This is at least a way in which we can get to that kind of common agenda setting. And so I'm optimistic around what Paul was saying, is that they're receptive to this, because the Conference of Deputies actually 5 weeks ago blessed this work. And by the end of fiscal, we hope to have generated a bit of a work plan and what the common agenda happens to be around data sharing, interoperability, et cetera, across the country.
That's great. Godspeed. Question from the audience.
Hi, I'm Vincent Martin Schreiber. I'm doing a PhD in nursing science here at the University of Ottawa. I have a question connected to cybersecurity and architecture, but you are talking about like a centralized architecture with Gemini. But since we are a federated country, why not have a different approach with the federated learning? Because that would probably make sense and make some of those things you are talking about, like in terms of different legal backgrounds, easier, and also because it represents single points of failure technically, because AI can do some cool stuff, but it can also really help to hack some systems. So, I mean, can you talk about that and maybe about cybersecurity in that new landscape?
Thanks for the great question. I'll turn it over to Kumanan more as well. But actually, yeah, you alluded to exactly the approach. So Gemini in Ontario does aggregate data. That's helpful. But in a multi-provincial context, it is a federated infrastructure, actually. So the build is each province will have a secure data environment for analysis within each province, and we will federate across the provinces. So that's exactly the architecture we're taking. So thank you, and totally agree. And if you want a job, come talk to me afterwards. That's the vision that we're going for. And I will say that I think that's also a response to the online comment about consolidation, which is like, let's be clear. Canada will never be consolidated in one. It is a federation. We will always have 13 different healthcare systems. And so that's actually a strength. Like we have, in learning how to create technology that works across 13 systems, we can create technologies that work in the world. You know what else is federated? Europe, right? Like there are markets around the world that need this kind of approach, and learning to do things here can create tools that is very useful globally. So yeah, thanks for the question. That's exactly the approach we're trying to take. Did you want to say anything about cybersecurity?
I think there was an initiative at FACT to do a federated data strategy, and it ran into some inertia at the provincial level. Hopefully that's changing now. But honestly, I think CIHI is the answer. I mean, you've got the data sharing agreements with the provinces. I mean, that was brought up earlier, and there've been challenges with data sharing agreements. Provinces generally don't want to do data sharing agreements with the federal government, but CIHI done an amazing job of having data sharing agreements with the provinces. You were in 30 registries already or something. Like we talked to them, like, why not make the immunization registry at CIHI? It just makes sense. They've already got the data sharing agreement. They've got, like, their data holdings are pretty amazing. So yeah, I think federated data, and the US does this a lot for particularly in the vaccine space, is one option. There are limitations for the analyses. But we already have consolidated data that's hosted at CIHI with information sharing agreements with a lot of the provinces, and why don't we just build on that? And they have they've established trust relationships, which we recognize are critically important.
Great. I'm going to go to you, Katie, but Vanessa, do you want to jump in and just say what's happening online?
There's lots happening online. So a comment and a question. So a comment about data absolutely being the main ingredient to successful AI, but the other, of course, is access to data. So the need to have robust, safe, and predictable interoperable infrastructure, a trust framework that enables the AI systems in predictable ways. And then a question, what can be done in the near term to accelerate use of the best AI tools to improve both acute and non-acute efficiency and quality in a way that works for clinicians?
These are questions from TikTok, right? I assume. Someone else want to take that? I mean, I sort of spoke a little bit about this. I think that there is there's a big evidence gap. Let's acknowledge that even for efficiency tools, there's actually very little real world evidence about how well they work, right? And that's a big problem. It's a big problem because I think we're at a position where in our decentralized healthcare system, where a lot of different people hold purse strings, there's a very reasonable chance that millions, if not billions of Canadian taxpayer dollars are gonna get wasted in the next 5 or 10 years on AI tools that sounded great but did nothing at all to help and maybe made life harder for clinicians and patients. So in that context, how do we find, like, the word best, I think, in that question is doing a lot of work. And I think first we need to insist on some rigorous kinds of evaluation. It doesn't always have to be a clinical trial if it's not a clinical facing solution, but I do think there's a huge role for health technology assessment for Canada's drug agency and our other sort of HTA bodies to be like, this we will pay for with public money and this we won't, because the evidence is just not there yet. And create laboratories where we can generate that evidence here in Canada, right? So I think that's a major part of it, and I'd love to see that be part of any strategy from the outset, is insisting on some really rigorous ROI measurement, economic measurement, even of these efficiency tools. And then massive clinical trials of AI. Like between 2018 and 2023, I say this a lot in Roots, there were only 86 clinical trials of AI solutions in the world. There were at the same time 100,000 clinical trials of medical therapeutics. So we need an infrastructure for clinical trials of AI, clinical AI solutions. That infrastructure does not exist in the world. That strikes me as an extraordinary opportunity for the kinds of platform types of trials that Paul is talking about. Like, Canada should be the place everyone comes to do their clinical trials of AI.
All right.
I just want to highlight the fact that we have some of the best clinical trialists in the world. Let's just start with that. People to help Amol do his job. We have some leading clinical trialists in this country, and I couldn't agree more. I mean, the worry is that, as Amol said, the risks of, wasting a bit of money is one thing if you're inefficient. The risk of killing someone because you make the wrong decision at a bedside, that's a different risk. So you need different tools for those different things. All of them will be unleashed with data, either way. Yeah. The issue is the methodology by which you go about it. And I guess at CIHR, that's the methodology part, and the question part, that's what we do. So, and we do have the means and the willingness and the programming soon to kind of do that.
Yeah, well done on the budget. Question?
So standing here, of course, most of my questions were answered. I think one of them is about the sort of provincial barriers. I think about, the build of Archimedes, which is, one of these kind of sharing platforms similar to Gemini in many ways. Are there interprovincial legislations about privacy? How do you get people to share data from two different, but I think it sounds like the works are there to move it forward. My question that remains is really about sort of liability, I want to call it. So at the end of the day, I think we're all probably in this room because we really want to. Yeah, I was going to say actually, calling Vanessa. Partially because I think that's some of the biggest barriers that I'm seeing. Is it's not for lack of desire to want to do this. It is not for lack of the data sets that we, even once we've all come together for data quality, as we talked about as well, right? We need quality data. There's hospitals, healthcare systems, health information custodians are scared to make the wrong choice. You mentioned, Amol, I think about like having like a list of trusted solutions that each hospital doesn't have to go, well, I don't know, it's not perfect, but if we use it, are we going to get in trouble, right? So how do we solve that? Is it, I don't think it's just a culture change. I don't think it's just leadership wanting to de-risk, and take some risk. I do think there has to be some on the other side of, if you try this, we're not going to come back to you and sort of, make you walk the plank because maybe it wasn't perfect. Where are we there? I think institutions would love to hear that.
Vanessa,
I would.
Okay, we've just promoted
yes,
Vanessa to a panelist.
Panelist.
Please.
Yeah, so I mean, I think that would be a pitch on my end to say, we do need some clear regulation of these tools, right? We want proportionate regulation. We want regulation that promotes innovation, but we do want some regulatory tools that are going to promote some certainty for innovators, for hospitals, for clinicians. And so I do think there's a lot of work to be done in that space to build a framework, a regulatory framework that strikes the right balance that we've been talking about. That's really where that legal policy governance piece.
And just to add, I also think that on the privacy side too, because I think that's also where provincially people get very, they think that any amount of, privacy breach risk is like a zero, like there's no way we want to do it. So, just maybe a comment on that for anybody else on the panel.
I would just say, wouldn't it be great if the Faculty of Medicine could work with the Faculty of Law on some of these things, Vanessa?
Wouldn't that be great, Kumanan?
Wouldn't that be a
Yeah, it
great
would be a
idea?
really great idea.
I think that'd be great.
Maybe, yeah, some money
And
would be
that's where I
great.
come in, is in addition to the legislative regulatory framework, we probably also need some funding models, because this is going to generate innovative models of care that actually don't fit within the current silos of funding that we have. And so there's a whole lot of rethinking that needs to happen. Yes, there is.
One of the
Kumanan.
things, I know we're in a single payer system, and people need to think of product market fit. Like, we don't get the best solutions, we get the solutions people are willing to buy. And so there are a lot of great solutions that never make it to market because nobody's willing to pay for them. And so Scribe is something that, okay, that makes sense, if someone would want to pay for that, but an algorithm that improves care, I mean, there may not be a market for it. And that's a hard thing to understand as a healthcare provider or a scientist, but that's the business reality. So Epic may not introduce it if nobody's willing to pay for it, even though it could save a whole bunch of lives. And I know that's not a lens we look at things, but there are a lot of algorithms coming out, and you have to decide which one that they're going to push forward. And so,
Ariane, you're going to jump in on privacy, I imagine.
Yeah,
There's
actually,
another lawyer in the crowd.
Thank you so much, Vanessa. You did a great job fielding that question. I'm Ariane Siegel from Ontario MD, and just such a great discussion. What fantastic panel. I think I really like the conversation around innovation. Ontario MD, actually, under the leadership of Ontario Health and the Ministry of Health, did an incredible engagement program last year on AI Scribe. And it actually sought to solve some of these issues in a practical way, identifying with Supply Ontario and other partners some of the critical issues that had to be evaluated from a physician and clinician perspective with respect to use of AI.
I haven't really looked at it myself. I just relayed information that my friend was telling me about.
Not on mute.
That sounds reasonable. Like, would
okay.
one of those days be to get up to
I
the
can
100?
talk
That
louder.
was just
And so at the end of the day, Supply Ontario identified vendors of record. Just had been suggested by the panelists that clinicians doctors could choose when adopting an AI Scribe that balanced a whole variety of regulatory concerns, medical legal considerations, privacy, ethics, and I think it's been a fantastic experiment. I'm not sure if it's 100% right, but it's certainly in the right direction.
We should learn from that. I'm going to try and get our last question in. Thank you, Ariane.
Really quick, and I don't expect a fulsome answer, but I can't help but ask from the Ottawa Academic Health Network, given that the element of trust in models and having the opportunity to test out, and particularly moved by your direction, Amol, on how using AI in health system efficiency contexts could be an easier funnel for building patient trust and system trust in using AI tools. What would the advice be for local networks of hospitals and research institutes? And are there any good examples of groups that have been at the forefront of good collaborative strategies? You folks have talked about a long list of tactics that require an enormous amount of integration of systems in order for there to be uptake. At the local level, are there groups that are doing this better than others, or at the strategy level, are there key elements of strategies for hospitals to work together a smaller level in order to prove out some of these systems?
Short answer is yes, but why don't you go ahead?
There are a lot of examples of coordination. So one of the things you have to think through when you think of your problem is, what are you trying to fix? So are you trying to fix a system, which is kind of a horizontal strategy, or do you trying to fix a theme of or a problem? So I'll give you the problem approach just because I'm thinking about that. Alberta, until recently, had a program called Strategic Clinical Networks. And in that, they decided to pick big, hairy problems as their approach. It was started off by Cy Frank and Tom Noseworthy. Some of you know Tom quite well. The whole program, the idea was to fix a big thing in their system. It's a form of coordination. So, you know, in a lot of what we do, we think of regional coordination, right? We think of access to and building out, the basket of services we offer. That's very horizontal. That's for everyone. In this approach, what you do is you make a whole bunch of doctors work with researchers, work with innovators to fix a problem. So in that thinking, for example, and I can give you examples in Ottawa where you do that, but in that form of thinking, you think, well, you think of a problem. Turns out people who have big strokes do much, much worse when you're in a rural area than in an urban area. It's a problem. It was a problem in Alberta. Their outcomes were awful in regions. So they got together, the stroke network, and they focused on that problem. And they put a whole bunch of systems in place, including data, to fix the problem. So when you're talking about coordination of activities, what are you trying to do? Which part are you trying to fix? My suggestion is you do need both. You need governments to set up the systems of integration across a region, which is what Helen used to do. And then you have to start thinking about getting a whole bunch of coordinated activities to fix a problem. In Ottawa, for example, at the Heart Institute, they've started to focus on a few of those. Katie can tell you all about her strategic plan, but the idea is to think of that form of problem solving. A region like Ottawa is ideal for that because we've got the right size and stuff like that. So if you want to walk away with an approach, I would suggest that our regional health authorities have to think like that. If I were me, I've suggested to Bruyère, they think of being the aging hub for a coordinated, system in our region. Palliative care is another one where you have to work across multiple disciplines in the hospital. It's what I do now for a living, in the hospital, in the clinic, in the outpatient setting, and in the home. They're wonderful opportunities to start bridging those gaps. Why does this matter to this conversation? Because data is usually the problem. So if you start integrating your programming, your data will follow. And anything we're going to build at CIHR and network activities and collaboration are going to be one of the things we do, we hope with the provinces in our SPORE program. Everything will have a data strategy attached to it where we strengthen our data, an innovation strategy. That's what Blake does for long-term care over there. It'll have a research strategy and a coordination function. So, and that's essentially the strategic clinical network model that I really liked before they took it apart in Alberta. I'll just leave it at that, but it depends on the problem you're trying to fix.
I think that's a wrap for us today. We're at 5:30. Just a couple of reflections. If, there's a call to action here that's really important and immediate. And I think everybody in this room, we just talked about what you could do locally. We haven't even talked about, should we be reintroducing the federal legislation or tweaking it given circumstances? Everybody's saying yes, but are there any changes we want? Well, it's kind of, yes, I'm not surprised.
Yes.
So there's just a lot of work to do. I think it's time to roll up our sleeves and get it done. As my premier would have said, get her done. All right.
That hasn't changed.
No, that has not changed. All right. Have a good evening. Thank you.